Good evening, everyone. Welcome for the second of this year. The first one was a masterclass, so we are back to basics. And a very good point to start off would be perioperative management, mainly about fluid management and pain relief. So I'm looking forward to learning. I'm Dr. Sanjay Adla. I'm a urologist and a uro-oncologist working in Apollo Hospitals, Hyderabad. And we have chosen Dr. Vivek because he has got quite good understanding of literature, because that's what we need to be, as well as has got a bit of grounding both in India as well as in Western health system. So he should be able to give us a better understanding of how to manage our patients and at least help us learn what we have been doing wrong. Welcome, Vivek, and thanks for accepting this.
Thank you so much, Sanjay sir, and thanks to the SOGO committee. So as Dr. Adla said, that this is a topic which will really take us back to basics. And when I started preparing for this, I thought, I probably know most of this stuff. But actually going through everything, I really learned so much that I'm actually very grateful to Sanjay sir for this particular topic. So the session will be divided into these 3 or 4 particular situations. We'll learn about perioperative fluid management, analgesia, specific requirements and challenges in robotic surgery, which is now probably the predominant type of surgery which we do in uro-oncology, and the principles and caveats of enhanced recovery protocols, because this is coming up in a big way and probably the last 10-20 years, and we've been talking about it ever since I was a resident as well, and somehow there are still parts of it which have not caught on. So why is that, and how we can do better? So when we go back to basics, we actually have to start from our first MBBS, the fluid physiology. The total body water is about 60% of a person's body weight. It varies with the age, gender, and the body habitus. The percentage of water in a human body in a fetus is much larger, and in an adult male is, like we said, about 60%, and in a lady about 50%. Of this, the intracellular fluid is about 2/3, and the extracellular fluid is 1/3. So the intravascular out of the extracellular is 25%, which is the plasma volume, which is what is targeted during any surgery preoperatively, intraoperatively, as well as postoperatively. And that is the main thing that we can adjust as clinicians. And the extravascular or the interstitial fluid is 75%. So this ECF, or the extracellular fluid, is the main intermediary between the cells and the environment, and all the changes of water, ions, and all important material between the intracellular fluid and external world occur only through the ECF. And the plasma is the only fluid which can be acted upon externally to maintain this ECF volume and osmolality. So our aim when we are doing any surgery is to maintain an adequate circulating volume to ensure end organ perfusion and oxygen delivery to the tissues. So this is the basic goal. And as we go ahead, you'll understand that the goal-directed therapy is what is very, very important. And our goal is to maintain this, whether we do it with a large amount of fluid or whether we do it with fluid restriction. This is what we are aiming for. And the only way to do that is to adjust the plasma volume. So when we assess a patient preoperatively, what are the things we are looking at? A lot of this takes precedence in an emergency situation. We are not always dealing in that way. In uro-oncology, we are dealing with mostly elective cases. But when we are assessing a patient, these certain signs will give us an idea of the patient's preoperative baseline status of hydration and such things. So the first is the mental status. Obviously, stupor or delirium, those are signs of a very severe either fluid or electrolyte balance. You have to know the intake and the output. Supine and standing blood pressure, because orthostatic hypotension is an important sign which indicates a fluid deficit of about 6 to 8% of body weight already happened